So here we first explored the distribution of data, trying to do ADA using the case of the DTP3. We did not use all the vaccine. We used DTP3. And we realized that doses of DTP3 follow a kind of constant trend over time with seasonality. As you can see, we saw an issue of seasonality. And of course, there were some peaks. When we try to look now at the district level, next slide, please. At district level, they were still the same, but it was showing that all the vaccines uptake were ranging between 500 and 2,000 doses per district per month. So here we realized that the peaks were due to Gasabo, and as you can see, there are some disconnections of the trend of Gasabo district. Reason why in the next slide, we decided to remove Gasabo. Next slide, please. We decided to remove Gasabo because of too much missing, but also, as you can tell, all other districts, the doses were following near linear distribution, which is the case for ITS. So for us to proceed with a good model, we realized to drop Gasabo data. Then we came up with the following slide. The following slide, yes. This slide shows us a kind of decrease. Yes, it shows a kind of slight decrease. However, after the introduction of e-tracker without considering all other variables, it seems like the introduction of e-tracker caused the uptake to decrease. But you remember, this has been introduced and immediately COVID emerged. So let's now continue and see how we now controlled for other variables, including COVID. Next slide, please. So we first controlled the seasonality issue as well as the autoregression, and noticeably the DPT3 uptake was kind of increased. You can see how the graph is changing over time. However, until here, our model is still not a good fit because you can see our R square is just 1%. So we controlled other variables, which is now COVID period, not COVID case. We also controlled the COVID lockdowns. These data were collected by all districts and per month, as you can, they are too small. So after controlling for all those, next slide, please. Next slide. After controlling for both seasonality, autocorrelation, COVID lockdown, and the COVID pandemic period, you can tell how now the model is still not good fit, but it shows that DPT3 uptake was decreasing. So up to here, our model was still not good until we also controlled for many, yes, thank you. From this table, this is for the final model with 92% of our R square adjusted. And you can tell surprisingly, the introduction of e-tracker only increased almost 1 dose per month per facility. However, it is not statistically significant. Only COVID pandemic, period, seemed to be statistically significant, and with a reduction of almost 42 doses per month and per district. So we go next. Those are what I mentioned regarding the model interpretation. You go next, please. Go next again. For the interest of time, let's just go to the final. Yes, this is now our final model, ITS model. which shows a slight increase of DPT3 uptake, though there is a slight increase which is negligible, but also it was found after adjusting for all seasonality, autoregression, COVID, and lockdown, and it gave us the good, a good R square of 92%. However, 92%, you can tell it is also, it is lacking this 80%, right? So in our limitations to this model, we were lacking COVID data, I mean COVID case, because we wanted now to have now the number of cases per month, per district, to know if it could also play anything with the model. And also, we were not able to get number of births because the time we were conducting this, there were no interoperability. But we thought it could also help us to control the number of uptake of DTP3 based on the number of births. The also other limitation we had is intervention decision, I mean transition period, because we wanted to incorporate transition period in this to see if probably there was no increase or decrease because of the long time it took to go paperless. But the time we ran this, we only had 6 months data points after they went paperless. So with all those, in conclusion, say that are not moving. Yes. In conclusion, although the intervention did not have a significant positive impact, it has slightly, as you have seen, changed the direction positively. And we think that because of pandemic, the doses went down noticeably in general. And now the intervention seems to be slowly increasing or changing the direction positively, which we hope that we may expect a higher over time under 2 following conditions. First of all, we think after the effect of COVID completely disappeared, and as well as after all the facilities go paperless, this is when we could probably get a good impact of e-tracker introduction to routine immunization. So lastly but not least, here are the implementation concerns we saw. Previous slide, please. The implementation concerns we saw at the facilities we visited, as I mentioned earlier, they were limited hardware to redirection. By the time we were doing this evaluation, most of the infrastructure, I mean laptops, internet, were directed to support COVID, and the use of tool by data manager rather than health workers. Actually, the e-tracker was designed to be used by the CHO or the API supervisors, although at the time of evaluation, we realized that only data managers would pull data from registers and enter in the system. And also, the equipment, laptop, I said most of, around 75% reported that they have not enough equipments. And there were 30% of them reported an issue of connectivity. Yes, they have internet, but their location, I mean their geographical location, does not permit them to have consistent internet, as well as 10% reporting the issue of electricity. And as we know, the e-tracker was to be used on real-time basis. So, yes, I think I've cleared these limitations, and that's all about my presentation. Thank you for your kind attention.
Thank you so much, Piero, for the wonderful presentation. Lots of insights, but I think for me the key takeaway is that there is digital uptake. but we still have 50% or so of the facilities that are not frequent users, and I think the move to completely go paperless is going to force adaptation and use of the data. It was also encouraging to see that at the subnational level, they're actually using that data for their decision support making. So we'll proceed to the next session, and then we'll have all the questions at the end, so please note them down, including the 2 questions that were for Aline earlier. So our next speaker is an AI expert. He's going to tell us all about what we need to know on how to leverage AI for MCH interventions. So please welcome Rukundo from AQS.
Thank you.
Yeah.
Thank you very much. Actually, I think the presenters were so good, actually, from Professor Janine and our moderator, Dr. Brenda, and the other panelists. Thank you very much for giving the opportunity. My name is Prince Rukonda. Actually, I'm a PhD scholar at BIT. It is a Beijing Institute of Technology in China. And also, I'm a researcher in AI tech. I'm a lecturer as well in the university. So the presentation follows this way. So I have like 3 parts. The part 1 will be regarding AI in maternal health, and then the second part will be the emerging technology. The third part will be the products that are now which are on the market. So next slide, please. Thank you. So the part 1 is the application in maternal health and other health-related research. Next, please. I want to give us a little definition of artificial intelligence as a tool which actually will behave as human being, and then we can solve and reason as a human thinking, right? So we did a tool, it's like a kind of machine or software, which help us to make sure someone called a machine is thinking as a human being, not taking that much decision as a human being, but which can actually adapt the way human beings are taking decision and are learning. So there is a lot of tasks that AI is doing. Basically, there is a machine learning task. There is NLP. We have a specialist in NLP. We have computer vision, speech recognition, and healthcare applications. So my tool was to present on healthcare. And if you need a lot of things can be actually in terms of classification, regression, NLP in text classification, sentiment analysis. It goes with the machine translation, computer vision. We have object detection, facial recognition, speech to text, text to speech, and so on and so on. So my topic now is to discuss about the healthcare application. Next, please. So AI in maternal health. Now, how can AI transform the maternal health? Here I try to bring a simple tool. We have a small ultrasound, a mother who is back home having his cell phone, and then powered with a Zheng Donghue, it is a Chinese name, I'll find the name of this tool, and then he can take this ultrasound back home. And this system synchronizes itself with the doctor, and then he can actually make sure he's diagnosed without moving back to the hospital. Now imagine if some health workers, Rwandan health workers, have this tool, cutting the cost, perfect in terms of diagnosis. So I think Professor Janine understands how much this one will be too much helpful. So because of the time, I need to rush. But basically, can you come back again? So no, next. Yeah, so there is an early detection diagnosis, fetus malformation. So this kind of problem are the problem which specialists only, when you visit a specialist in the hospital, they can tell you about this one. But now, there is a cheap tool. I think this tool does not even cost $800 in China. So this shows you how it's cut off automatically. Next part. Next, please. Yes, there is another thing, maternal wearable devices. So here we have a mother who is pregnant, and then he has a wearable device technology. And then this can check the blood pressure, the heart rate, and the fetal movements. Now, he doesn't need to go to the hospital too. The wearable devices are available. Cheap one. But you have to go with quality. I think with $100, you can get this wearable device. So again, if we try to customize it in our situation in Rwanda, to make a difference. So that's very simple. A wearable device, if there is any problem, there is a for computing, a cloud computing ways, and then automatically data are analyzed on the cloud. It gives the classification, it gives detection, and then it informs automatically the health worker, and then they can take immediately response to the problem. So these are things which are not yet in Rwanda, but I think it's easy to bring. So next line. So there is another thing like a preview wearable pregnancy ultrasound. It's another tool, very simple tool. A mother wear it, and then he can interact with his baby. In other words, it's a construct 3D image where a baby can be interacted with the parents. You can check the movement, you can check the face, try to reconstruct the face. And then there was a problem of Professor Jennings said about mental health. Sometimes a mother who is pregnant, he may feel the pain of a baby in the womb, but if there is a tool which shows him actually what is inside the baby, this also can reduce stress. And as we men, we like to see our babies when they're pregnant. This can also be another tool which boosts our energy up. So these tools are available. So I think there is a lot of things not to read, but it can detect a lot of things. Next, please. And then what is the next step of AI in maternal health? Now, what are we looking for? We're looking to enhance the predictive analysis, integration of wearable device, I talked about it, telehealth and remote monitoring. If there is a wearable device, we can monitor the status of a mother, regardless of the direction. There is this NLP. So how many records do we have in hospital in terms of written records? Like you come, a patient writes your problem you're having in terms of text. Now imagine if those texts were analyzed and we could reconstruct a knowledge which can help us to take decision. We don't even have an integrated system where, for example, if today I was in A hospital, B hospital, C hospital, those diagnoses should be combined together, and we apply NLP to bring an insight and construct a knowledge that can be actually an insight for the next doctor who's going to take a decision on what I'm suffering. So NLP, it's another way we have to look in terms of, and finally we have maternal mental health monitoring. This is what Professor Jennings was talking about. This also, there is a solution. There is a way we can work on it. So next, please. The part 2, they told me also to talk about, back. To talk about, back please, back. To talk about the emerging technology with AI, health tech. Now this was the maternal health. Now let's look now the emerging technology, still in health area. Next please. So on trend area where AI is contributing most, medical image diagnosis, drug discovery and development, drug repurposing, and then natural language processing, robotic in surgery, genomic and precision medicine. This goes with the genes and how to analyze genes and find a conclusive topic. So these are the most, I try to make a research, these are the most area in health that AI is actually impacting the most. Next, please. So let me discuss on these two. Just two, there are many, but we have less time. So one is medical image diagnosis, another one is in drug discovery. What AI is doing in these two fields. Okay, next, please. So there is something called generative AI. I think you've heard about it. I took a simple test. This is Leo Messi, the footballer. And then I go in a generative AI. I write, Lionel, give me an image of Leo Messi cooking ugali. This is a local food. And in a second, I got this picture of Messi cooking ugali. So basically, they don't know ugali, they don't know Messi. But this technology, generative AI, can generate this type of information. Now, I was like, how can I bring this one in the health sector? Next, please. So there is a lot of models of generative AI. There is these GANs. There is a variation autoencoders. There is autoregressive models. There is Boltzmann machines. These are kind of generative AI which are working. But there is some technologies which are converting those knowledge in medical health. So I took a case study. Next, please. I took a case study of a generative AI. So Gen AI can be used in drug discovery. So let's say, for example, we have two molecules. Gen AI can understand different molecules. So, and that application accelerated the drug discovery. I took a case of a simple molecules. Next, please. I say, for example, I'm having a paracetamol and I'm having an aspirin. Two molecules. So as you know, aspirin has a side effect of stomach pain. And second of all, I want to combine these two molecules into a single molecule, and then it has also to treat another disease, which is like cough. I say now, give me two molecules, combine them, and then make sure there is another molecule which accepts the combination of two, which can treat both stomach pain, which can treat fever and cough and headache. But basically, remember, there is no cough in these molecules. So Gen AI is able to propose you another molecule which will make sure the combination of two does not have any side effects, will cure both headache and fever plus cough. It's wonders. So, sorry? No, this is an example. This is actually have a paracetamol and aspirin. I'm not from chemistry, but it was a kind of an example I found. So now a combination of two, we get a very good molecule, molecule, and then with a less side effect. So Gen AI is now where we are heading in terms of technology. And the question is, can we do it here in Africa and in Rwanda? The answer is yes. Great. Now, next, please. So this is application in pharmacy. So there is another technology. This is my last presentation, which is augmented reality with AI in medical fields. So we should not confuse the augmented reality with VR, virtual reality. So augmented reality a bit different with virtual reality. So now, how does augmented reality is making a very big impact in health? This man is wearing some glasses that we call HoloLens. I think you've heard about it, HoloLens. Now, what is HoloLens doing nowadays? HoloLens, you wear a HoloLens, you have a scan device. Now, the HoloLens will reconstruct a 3D image where you can easily interact with the patient body on the 3D image. You can reconstruct a 3D image, and then you can make sure you can have a precondition of diagnosis even without touching the patient. And then when the operation is going on, you can still interact with the patient as if you were there. For example, there is a scan image here. So this person has scanned the skull, even the... Yeah. He scanned the skull, and then now he's able to take the 3D image reconstructed and separate the skull part, the frontal bones, the side bones. Okay. Next, please. So this is a heart scan. So the person is able to take the 3D reconstruction, look outside of the hearts, decide where to make a surgery without touching the body. Just an image. You can rotate the image. You can look backside, inside, and so on. So next, please. So these are the technologies that are available that we can have here back in Africa, in Rwanda. So now we have two projects in partnership with AQS and Ihene Goats Limited. We've got two projects, and then one of them is actually a platform which accepts different medical imaging. It can be CT scan, chest X-ray, PTS, CT, DEXA, and so on. And then that platform is working. We have it now. And then you don't need to be, it actually invites different radiologists, medical doctors, patients, even technicians. And then we can have an image. You go to the hospital, you get your CT scan, they upload in the system. The system automatically analyzes the images, and finally it gives you the recommendation. In other words, the system will tell you, you're having this cancer, automatically. You don't need any radiologist to do so. You're having this cancer. This is the place where the cancer is concentrated. This is the diagnosis. This is what you're going to text you to get the process of cure. And then this is how you can take a step forward to be cured. So we developed this system, and it's working. So we developed a second system which actually detects most of the cancer, like brain cancer, tumor cancer, prostate cancers, and other kind of diabetes in terms of iris scan. So we're having this system working, and it's our pleasure really to share that there is something which is being done here that people can benefit from. So thank you very much. This is actually the screenshot of our developed system. So we're having both the doctor, the patient, technician, even the radiologist, and then it can give you a clear view of what you're suffering. So next slide, please. So this is a tool we developed to detect COVID, pneumonia, and low respiratory diseases like COVID. We have asthmas. So just give us an image. You can use it. It's free. You log in online. There's no login. You upload your image and it tells there is COVID, there is pneumonia, there is even low respiratory diseases. So I can give you the links, and then you can try explore what actually the tool is doing. So thank you very much. If there is any question, I'm happy to take it. And then, yes, please.
Just a question on the hi, my name is Zuki. On your first slides, when you were talking about the pregnant mother, I just want to, I think I'm audible. Oh. Oh. Okay. Okay. So with the wearables and all the other tools that you showed us for the mother, can the mother interact? So when the data is collected, can the mother interact? Let's say, for instance, they're wearing a tool, or they're using one of the tools that you showed us. They can, after they've registered let's say the temperature, they can click a button to move on to something else, or is it interactive? That's what I want to know. Because what I'm looking at is we're gathering this information for the health worker, but at the same time we kind of want to empower the patient as well, without them curing themselves, if that's the word. So are they interactable?
Yes, thank you very much for the question. Yeah, actually those tools, they can interact with the mother. There is, first of all, they can give an alert or even ring. For example, if they have the blood pressure rise up, the tool rings or can even vibrate on your arms. And then it can tell you, you can customize it in a local language. You can also try to make sure that all the, if let's say, for example, if he doesn't wear it, it's harder for it to detect. But again, when you put it on his arm, there is those kind of notification that a mother can know I'm in trouble. And then when the signal is coming, automatically the health workers, they're also aware of the problem, and they can either call him and come for the assistance as soon as possible.
Thank you so much, Rukundo, for the presentation. So we'll take a few more questions. We only have 5 minutes left. So please address your questions. We still have Piero here. We have Aline and Rukundo. So please address your questions to those three. And please be concise and brief. And please stand up so that the online team can see you. Or come in front.
Stand up. Thank you very much, Sam Malamba, CDC. Just a question on, do we have articles that have been published on these presentations? Because the text was very small, we couldn't see. And the question is on the nutrition and malaria. We moved from a very big number and we dropped to only 85. The title was talking about a district, specific estimates. And the summaries were on a provincial level. I'm wondering, do we have power to that level?
Let's take 2 more questions, then you'll answer the end.
Thank you. So my name is Jean-Pierre. The question I wanted to ask, my name is Jean-Pierre. So the question I wanted to ask before to Dr. Aline and Professor Chondo was if there were next steps to dive into microbiome, because there's a huge interaction between infections like malaria, nutrition, and also microbiome. So, because now there's an emerging understanding. There's an emerging understanding that microbiome affects a lot absorption of the macro and micronutrients, and also that microbiome affects the absorption, but also affects directly how the pathogens behave, and also mental health, like depression and so on. So it would be good if you could also include this analysis in the next phase. Thank you.
Thanks. Perhaps Dr. Aline can respond to those 2 before she forgets them.
Yes. Thank you, Professor and Dr. Jean-Pierre. So he was asking if there is a paper on this because it was not readable. The paper is the stage is under finalization. So upon published, we share it widely so you have all the information related to this work which have been done. So the other point when you ask about the power, because we have excluded some numbers to remain with those who have, individuals who have data who are valid, then 85, it was not powered. That's why we opted to continue doing data collection, which is still ongoing. So as of now, we have recruited other additional around 600 cases, so which will power the information we are trying to. This was a preliminary finding showing what we have on field, but to have something which is reliable, then we opted to increase numbers of sample size so we can have something which is tangible. To respond to Dr. Jean-Pierre for his question on microbiome, this is also part of this project. It's something we are collecting also stool. We are doing DNA extraction, the analysis to look on different microbiome those people we have, they do have in their guts. And this also will be coupled doing the analysis. And also the other thing I didn't mention, it's the density parasite of Plasmodium they do have. So also can show us the way this subject we do have also looked on anemia and other aspects. So it's, we do have different elements we are looking. So what we can say when it's published, it will be disseminated, and all of us, we have the chance to get the results and try to translate it into some brief for the program, and also being used for the with other scientists within the region or elsewhere. Thank you.
Any questions online? Just 1 minute left. Right, our time is way past. We are at 13 minutes past the hour. So thank you so much for all the
Okay, thank you. I just wanted to mention that the full report of what I presented is available on our website, seeking.org. You can feel free to jump there and get a final report. And the paper is under finalization as well. Once submitted, you also find the link on our website. Thank you.
Thank you so much. So as we conclude, I think we've had 4 wonderful presentations, starting off with Prof. Chondo, that showed the status of quality of care, actually, within both antenatal and postnatal care, and there were key recommendations that need to be taken up that will increase the uptake of the complete package of services at every visit that the mother is expecting, but also highlighted the very high rates of mental health issues that mothers face during and after pregnancy, which is an opportunity to intervene and integrate mental health services within the MCH services. All right. Before I finalize, there are a few questions on YouTube that have just come in. Thank you, Liz, for the questions. And I think this is for Rukundo. How have you validated the diagnosis made in the COVID chest X-ray reader, and how do you verify that what's uploaded is an actual image for a diagnosis that's capturing the full lung fields, and that only the PA view is enough and the lateral isn't needed? Yes, and clearly we have a lot of more granular details that we can get into, but you can quickly respond to that and provide your parting shot as we close the session today.
Thank you very much. Actually, validation and image, I didn't mention that this application is using chest X-ray images, and we tried to make sure we have a different data set. Try to make sure we have different data set from different data repositories, and then we try even to use pre-existing models, because we still have transfer learning models, we have handcrafted models. So our model, we constructed a model which actually combined the two, the pre-existing and then handcrafted, to make sure we have at least one which is reliable, and then with less time to train and predict. And finally, we try also to make sure the model is really working in terms of regardless the chest X-ray or the CT. So we make a validation. We have a patent. We went in RDB, and then we've given the model. They tested in different data sets, and then they validated it. So I didn't mention that the patent is available. So it's really well validated with government institutions. I think that's most I can answer.
Thank you so much, Rukundo. I think in addition to that, we still have a pathway to scale that we need to follow for all of these AI interventions that are going to revolutionize the way we do healthcare in our country. One last question. We really need to close.
Sorry, actually, I think it is an important question. I will ask to Prince, because when you presented in the first slides, you showed the wearable devices. Showed like a woman, a pregnant woman, can use something like maybe ultrasound, and he can check. Do we have those ultrasound, portable ultrasound here in Rwanda? What's the name of the devices? Portable devices, yeah. Yeah, no, I mean, because in the presentation, you showed it, like a pregnant woman. She can scan herself at home. Oh, so that's my question. Do you have that kind of ultrasound in Rwanda? No, they are not there.
But it's an opportunity.
Yeah, that's actually. Yeah, that's because actually I was asking. Actually, I work with Card Africa, so we are working on one software for fetal biometrics. So we are using a low-cost ultrasound probe. So that's why I was asking the question if it is there. Okay. Thank you so much.
So there are lots of opportunities, and I think the purpose of this discussion was to really open our eyes to the opportunities that are available, potential for collaboration. So please link up and talk to each other and continue the discussions after today. Unfortunately, our time is really, really time bad, and we'll have to close. But thank you to all our presenters, to Prof. Chondo, to Rukundo, to Piero, and to Dr. Alain. We'll see you again on the last Friday of next month. The topic will be communicated. If we don't have your contact, please put it in the chat and we'll add you to the mailing list. And for those that are in the room, please ensure that you keep coming back. Thank you so much and have a great rest of your day. I'll hand over to you.